Welcome, Zoassembliers! My name is Zouk Azalishvili and I'm the founder of Zoassembly. Zoassembly is an online podcast for the highest yield basic science and clinical knowledge tested on UAssembly Step 1 and UAssembly Step 2 CK. The information discussed in this podcast is intended only for educational purposes. It's not intended to prevent, diagnose, or to treat the medical conditions in real clinical practice, nor is it intended to reflect the policy and the guidelines of various health institutions. Simply put, we serve you to butcher your step exams. Please subscribe to our podcast, Facebook, Instagram pages, and the YouTube channels down below in the description of this episode so that we keep you tuned for the news at Zoassembly. Now, let's start rolling. We are continuing our psychiatry series, and the first section of the topics that we are going to discuss today is the mood disorders. So let's talk about the mood disorders in general at first before we dive deep into each specific mood disorder. As the name implies, the mood disorders are the conditions which affect the mood or internal emotional state of a human being. Right? And this is a very important thing. We should know the difference between the mood and the affect, right? So the mood is what you feel internally. It's the internal state of your emotions. But the affect is what you express externally. In other words, the affect is the external expression of the mood. And interestingly, the mood and the affect don't have to be congruent with each other. They may be incongruent. In other words, the patient or the person may feel depressed or sad, but she or he may behave like they feel normal and they feel happy. So their mood is depressive. However, their affect is normal or happy, and it can also happen vice versa. The point that I'm trying to make here is that the mood and the affect are not always congruent with each other. Another important thing in regards to the mood disorders is that mood disorders impair the social functioning of the patient, and that's the general rule of thumb in psychiatry. I think we have already mentioned it in the previous episodes, but still, let's repeat that. In order for any condition to be diagnosed or to be considered as a psychiatric disorder, that condition or that emotional state should be impairing the person's functioning. If that state of the person does not impair the functioning and overall life of the patient, then it's not the disorder, but it kind of mimics the disorder, but still it's not the disorder. The main mood disorders that we are going to discuss are the major depressive disorder and the bipolar disorder. However, each of these two disorders have their subtypes and the different variations, which we'll also discuss in detail. One more important thing before we go on to specifically talk about the mood disorders. The mood disorders can be accompanied by psychotic symptoms. Could you please remind me the psychotic symptoms from our previous psychiatry episode? Absolutely amazing. Exactly. The psychotic symptoms include hallucinations, delusions, and disorganized speech and behavior. Again, if the mood episode is very severe, it can be accompanied by psychotic symptoms. And the reason we need to remember this is that we need to differentiate mood disorder with psychotic symptoms from the schizoaffective disorder. And let's remind ourselves from the previous episode that schizoaffective disorder has the episodes and components of both schizophrenia and the major mood disorder, either depressive disorder or the bipolar. However, in schizoaffective disorder, the patients should have more than 2 weeks of only psychotic symptoms. This is how we can say that schizoaffective disorder consists of two separate diagnoses together, which is schizophrenia and the major mood disorder. Okay, this was our general overview of the mood disorders. And now let's move on to each of them. And the first mood disorder that we are going to discuss is the bipolar disorder. The bipolar disorder, as the name implies, is characterized by two different emotional states. That's why it's called bipolar. The one pole is the manic episode or hypomanic episode. This is when the person has the latent mood and has different symptoms that we are going to discuss in a bit. But the second pole is the depressive pole, where the patient experiences depression. There are several subtypes of bipolar. The most important ones are bipolar 1 and bipolar 2. Now let's explain how we can differentiate bipolar 1 from bipolar 2. If the patient has at least one manic episode, this patient is automatically considered to have bipolar 1. What I'm trying to say here is that the absolute criterion for the bipolar 1 is to have at least one manic episode. And then that manic episode may be accompanied either by a hypomanic episode or depressive episode. And they may be separated by any length of time. So it really doesn't matter if the patient has the hypomanic or depressive episodes after the manic episode. As long as the patient experiences at least one manic episode, that's automatically the diagnosis of bipolar 1. Now, in case of bipolar 2, the patient should not have the history of manic episodes. The way we can diagnose the bipolar 2 is that the patient has the history of the hypomanic episodes and the depressive episodes. Let's pay attention to one thing. In bipolar 2, the patient should have the history of the hypomanic and depressive episode. It's not enough to have just one hypomanic episode to say that the patient has bipolar 2. The patient should have the history of both. But again, the patient should not have the history of the manic episode. Usually, between these mood episodes, the patient's mood and the patient's affect stabilizes and normalizes. A very important and a very high-yield thing to remember is that the use of antidepressants in patients with bipolar disorder can trigger the hypomanic or manic episode. And this point is also very clinical. When the patient comes to the physician with the signs and symptoms of depression, one of the most important questions that the physician asks to the patient is if the patient has experienced the symptoms and signs of the manic or hypomanic episode. This way, we are trying to find out if this patient has bipolar disorder or major depressive disorder or unipolar depression. And we are doing this because if we think that the patient has depression, while in reality she or he has the bipolar disorder, and then if we prescribe the antidepressants, then this patient will deteriorate and will bring that patient to the manic or hypomanic episode. Okay, the bipolar disorder, as well as the major depressive disorder, are associated with the high suicide risks during the mood episodes. And the treatment for bipolar disorder includes the mood stabilizers. The first and the most important mood stabilizer is the lithium. We'll talk about the indications of lithium and the side effects of this drug in more detail while discussing the psychopharmacology, but here I would just like to tell you which mood stabilizers we use in bipolar. Apart from lithium, there are three anticonvulsant medications which have been found to have the mood stabilizing effects. This is valproic acid, lamotrigine, and carbamazepine. The thing that I'd like you to remember about lamotrigine is that it's not prescribed in the manic or hypomanic patient. It's usually prescribed as the maintenance therapy. And then if the mood stabilizers don't help, then we can add the atypical antipsychotics to the patient's regimen. The antipsychotics like quetiapine. We have discussed the bipolar 1 and bipolar 2, and now let's briefly describe and define what the rapid cycling bipolar is. Well, the rapid cycling bipolar disorder is the bipolar disorder in which the patient has at least 4 mood episodes per year. And the last disorder in this subsection that I'd like to talk to you about is the cyclothymic disorder, also known as the cyclothymia. The easy way to think about the cyclothymia is that it is the mild form of bipolar disorder. And the cyclothymia has the very specific timeline and the time frame in order to diagnose the patient with this condition. So cyclothymic disorder should last at least 2 years. The symptoms should be present for at least half of this time, half of these 2 years, and if there is any remission at all, this remission should last less than 2 months. So there are many twos here, right? At least 2 years and less than 2 months. The cyclothymic disorder looks like the bipolar 2 because the patients may exhibit the signs of the hypomanic episode and the signs of depressive episode. But here's the thing. The way we can differentiate bipolar 2 from cyclothymic disorder is that bipolar 2 patients have hypomanic episodes and the depressive episodes, while the patients with cyclothymia have hypomanic symptoms and the depressive symptoms. You're probably asking or thinking why I'm stressing the words episodes and the symptoms. This is because when we say that the patient has hypomanic episode, we mean that this patient meets all the necessary criteria for the hypomanic episode. The same is true for the depressive episode, and we'll talk about these criteria in a bit. But when we say that the patient has the hypomanic symptoms or depressive symptoms, it means that the patient has one or two or minor amount of the symptoms characteristic of these episodes, but this patient does not meet the criteria for the hypomanic episode or depressive episode. Okay, now that we've talked about the different types of bipolar disorder, let's define what the manic episode is and then what the hypomanic episode is. The manic episode is the state of elated mood, expansive and irritable mood. At the same time, patients in manic episode have excessive energy and they do many different things at the same time. The official criteria for the manic episode is that the symptoms should last for at least 1 week and the patient must meet at least 3 of the 7 criteria or the 7 symptoms characteristic of the manic episode. The signs and symptoms of the manic episode can be easily remembered by the mnemonic dig fast. So the manics dig fast. D stands for distractibility. It means that individuals in manic episode cannot focus on one thing for a long period of time. They are very distractible. I stands for impulsivity and indiscretion. In other words, manic patients engage in the activities without any regard to the consequences. For example, they may drive the car with super high speed, not caring about the risk of the car accident, or they may engage in unprotected sex, not caring about the consequences of this activity. The G stands for grandiosity. Patients in manic episode have the grandiose or inflated self-esteem. They think that they can do anything. They think that there is nothing that they cannot do. F stands for flight of ideas. And this sign is pretty much self-explanatory. They cannot concentrate on one idea for a long time. So their mind jumps from one idea to another in a very short time. So these ideas literally just run through their minds. A stands for goal-directed activity, also psychomotor agitation. The patients in manic episode are very concentrated on their plans. For example, they may decide to found a new company, and the increased goal-directed activity can manifest as lending money from the bank to found the company, or they may start to look for the employees. This can count as the increased goal-directed activity. The letter S in the mnemonic dig fast stands for sleep, decreased need for sleep. The manic episode is characterized by patients who may need only 2 or 3 hours of sleep per night, but they are still energetic and they can still function the next day. Sometimes they don't sleep at all, but they can still function. And then the T stands for talkativeness or the pressured speech. Again, the patients in manic episode talk too much, and they may also have this pressured, hard speech. The thing that we need to remember about the manic episode is that the diagnostic criteria, the signs and symptoms of manic episode are the same as signs and symptoms of the hypomanic episode. So hypomanic episode should also be diagnosed by considering these 7 signs and symptoms remembered by the mnemonic dig fast. Now, what's the difference between manic and the hypomanic episode? Well, manic episode is much more severe than the hypomanic episode. And the way we can tell that the patient has the manic episode rather than the hypomanic is that the patient meets at least one of these separate 3 criteria. First, manic episode impairs the social or the occupational functioning of the patient. In other words, the patient may get into the conflict with the family, with friends, with loved ones, or the patient may resign from the job. Again, there is some kind of occupational malfunctioning or social conflicts or social tensions. The second criterion is that manic episode can be accompanied by psychotic symptoms like hallucinations, delusions, or disorganized speech and thought. And here's the thing. If the patient has the symptoms of manic and hypomanic episode, and then you see that the patient also has the psychotic symptoms, this is automatically the manic episode. The hypomanic episode never has the psychotic features. Again, if you are not sure whether the patient has manic or hypomanic episode in the question stem, but then if you see the psychotic symptoms, that's 100% manic episode. And the last criterion is necessity for hospitalization. If the patient's mood episode is so severe that she or he needs hospitalization, that's also a manic rather than the hypomanic episode. Okay, now let's talk about the hypomanic episode. Again, we said that the Dick-Fast mnemonic is the same for both manic and the hypomanic episodes. But again, the hypomanic episode does not cause the social and occupational functioning, does not necessitate hospitalization, and does not have the psychotic symptoms. Patients in the hypomanic episode simply have excessive energy and they can be super productive. They can do their job day and night and they can be very, very productive in this episode. And the time frame for hypomanic episode is also different. If you remember, we said that manic episode is accompanied by the manic signs and symptoms for at least 1 week. But for the hypomanic episode, the signs and symptoms should last for at least 4 consecutive days. Okay, now that we've discussed the bipolar disorder, manic and hypomanic episodes, then we can move on to the other mood disorders. Let me tell you about Match a Resident. Match a Resident is an organization that helps residency applicants find the perfect residency programs for them. Although it's particularly helpful for international medical graduates, anyone is welcome to Match a Resident. It is trusted by over 150,000 international medical graduates for over 17 years. Match a Resident gives you detailed information about each program's requirements, such as visa status, USMLE scores, and more. Match a Resident annually updates these requirements through in-person conversation with program coordinators every year to give you the newest information possible. This way, you invest your time and money in the residency programs where you have high chances of matching. To find out more about this amazing organization, check out the website www.matcharesident.com. Match a Resident is the path to your success. Now let's move on to the major depressive disorder. The major depressive disorder has very specific time frame criteria and also the symptomatic criteria. The MDD symptoms or depressive symptoms should last for at least 2 weeks in order to say that the patient has major depressive episode. And the patient should meet at least 5 out of the 9 symptomatic criteria or out of the 9 depressive symptoms. And these symptoms can be remembered by the mnemonic depressed mood plus SIG-E caps. So the first symptom is, and it's very clear, is the depressed mood. The patient may come and complain that they feel down and they feel unhappy. Now the S in SIG-E caps stands for sleep disturbances. The patients with major depressive disorder may have insomnia or they may have hypersomnia. So they may have hard time falling asleep or maintaining their sleep, or they may be sleeping for more than enough. We have different types of insomnia depending on which part of the sleep is affected. We have initial insomnia, middle insomnia, and the terminal insomnia. Initial insomnia is when the person has hard time falling asleep. The middle insomnia is when the patient wakes up multiple times per night. So the patient has trouble maintaining the sleep during the middle part of the sleep. And then terminal insomnia is when the patient wakes up very early and cannot go back to sleep. The major depressive episode is usually characterized by middle and terminal insomnia, while anxiety disorders, which we'll discuss in this episode, are characterized by more of the initial insomnia. Okay, now the letter I in the word SIG-E-CAPS stands for interest. The patients with major depressive episode have decreased interest in the pleasurable activities. This is also called anhedonia. Hedonia means pleasure-seeking activity. So anhedonia means no quest for pleasure or no seeking of pleasure. And the patient may come and say that they no longer enjoy going out with their friends. They no longer enjoy socializing or playing some kind of sports, anything that was pleasurable for them. They may say that they no longer enjoy cooking if cooking was something that they loved. The G in SIG-E-CAP stands for guilt. Guilt and the feelings of worthlessness. The patients with MDD may come and say that they feel they are nothing, or they feel that everything is their fault. And if there is any kind of tension in their family or with their loved ones, they may think that this is their fault. E stands for energy. The patients with MDD usually have low energy. C stands for concentration, but it also stands for indecisiveness. When the patient experiences the major depressive episode, she or he may have hard time focusing on one thing at a time, or they may find it difficult to focus on anything at all. Very commonly, when depressed patients come to the physician, they may need the questions to be repeated because they cannot concentrate on the questions that the physician asks them. Appetite is what A stands for. There is appetite and the weight changes in the major depressive disorder. And this change may occur in any direction. The patient may eat less than normal and then he or she may lose weight, or on the contrary, the patient may eat too much and then he or she will gain weight. And finally, S stands for suicidal ideation, which is pretty much self-explanatory, right? Does the patient want to kill himself or herself? That's the question. And we'll talk about the difference between the suicidal ideation, intent, and the plan when we move on to the risk factors for the suicide completion. But for now, let's recap the fact that depression is diagnosed when the patient meets at least 5 out of the 9 depressive symptoms. And these 9 depressive symptoms include depressed mood and SIG-E-CAPS. A very high-yield point to make is that children or teenagers may have irritability as the major sign of depression. So in case of children and teenagers, the depressive symptom criteria can look like this. So irritability and SIG-E-CAPS. Again, when you see the teenager or the child who has decreased functioning and is constantly irritable, just consider the major depressive episode as one of your differential diagnoses. Another important thing to realize about the major depressive disorder, and actually for all the psychiatric disorders, is that the board questions describe the symptoms. They won't tell you that the patient has the guilt, patient has sleep disturbances, the patient has appetite and weight changes. No, they will describe it. For example, the patient may say, everything is my fault, and this is when we should realize that the patient has the sense of guilt. Or the patient in the question stem may say that they have hard time doing the puzzles because they cannot focus. And we should realize at that moment that this is the manifestation of decreased concentration. Again, my biggest advice about these diagnostic criteria is to analyze them, not to memorize them, but to analyze them and to imagine what the patient would say if he or she had this or that symptom. Okay, the treatment for major depressive disorder is antidepressants and cognitive behavioral therapy. The first line antidepressants used most of the times for depression is, can you finish my sentence? That's amazing. The first line antidepressants for MDD is SSRIs, selective serotonin reuptake inhibitors. The antidepressants alone have been proven to be effective for MDD. The same is true for CBT, but here is a very high yield point. CBT combined with antidepressants has the highest efficacy in the treatment of MDD. In other words, if the patient has both antidepressant and CBT as his or her treatment regimen, then that's the most effective treatment regimen for the MDD. The alternative antidepressants for the patients with major depressive episode may include SNRIs or serotonin norepinephrine reuptake inhibitors like venlafaxine, levomilnacipran. The other antidepressant may be mirtazapine. Mirtazapine is especially helpful if the patient has severe crippling insomnia, because mirtazapine has the sedative effects due to its antihistamine mechanism of action, and therefore it can help the depressed patient fall asleep. At the same time, mirtazapine increases the appetite. If the patient with major depressive episode has decreased appetite and weight loss, then mirtazapine might be a reasonable antidepressant for this patient. The other alternative can be bupropion. Bupropion is norepinephrine dopamine reuptake inhibitor, and bupropion has the favorable sexual profile. In other words, it does not cause the sexual dysfunction in contrast to the SSRIs, for example. And if the patient has the erectile dysfunction or generally sexual dysfunction as the major concern, then bupropion can be a reasonable antidepressant. If the major depressive episode is very severe, then we can also use the electroconvulsive therapy. We'll talk about electroconvulsive therapy in detail in this episode, but for now, let me tell you that electroconvulsive therapy, or ECT, is when we deliver the electricity to the patient's brain. And sometimes ketamine can be used for major depressive disorder as well. Now, major depressive disorder may look like the grief or bereavement, and we should definitely know how to differentiate major depressive episode from grief, and we'll talk about this a little later on. Okay, we have already discussed the major depressive disorder, but now let's go to major depressive disorder with psychotic features. The name of this diagnosis explains everything. Again, we have all the criteria for major depressive disorder, but the patient has psychotic symptoms as well. And psychotic symptoms, as we all know, include hallucinations or delusions or disorganized speech and thought. These psychotic features are usually mood congruent. In other words, they are the hallucinations and delusions which are depressive. They may have depressive themes of inadequacy or punishment. The patient may have nihilistic delusions, like as if the world doesn't exist, or they don't exist, or they are dead. Okay, and the treatment for MDD with psychotic features is the antidepressant with atypical antipsychotics. Again, we have MDD, which should be treated with antidepressants, and then psychotic features, which should be treated with atypical antipsychotics. Electroconvulsive therapy can also be used for MDD with psychotic features. Okay, now let's move on to the MDD with seasonal pattern. This condition was previously known as the seasonal affective disorder. And as the name implies, this is when the patient experiences the major depressive episodes with all of its criteria during the specific seasons of the year. Most of the times, the MDD with seasonal pattern manifests in winter. And the reason for this is that in winter, the days are shorter. Therefore, there is insufficient light exposure of the patients, and this may trigger the MDD with a seasonal pattern. The official diagnostic criteria for MDD with seasonal pattern is that the major depressive episodes should happen for at least 2 consecutive years, and generally they should happen in most years across the person's lifetime. MDD with seasonal pattern is associated with atypical depressive symptoms more rather than the typical depressive symptoms. And when we talk about depression with atypical features, I'll tell you what the atypical symptoms are. Well, the treatment for MDD with seasonal pattern is also very clear. Of course, we need the standard MDD therapy, which may be CBT or antidepressants or CBT plus antidepressants, and we need the light therapy. The light therapy can be beneficial in patients with MDD with seasonal pattern, especially if the episodes occur in winter when there is insufficient light. Okay, now let's move on to the persistent depressive disorder, also known as dysthymia. Persistent depressive disorder, as the name implies, is the persistent depressive state. PDD should last for at least 2 years in adults or for at least 1 year in children and adolescents. At the same time, the patient should have at least 2 of the depressive symptoms. And these symptoms are the depressed mood plus CG caps. Could you please remind me how many symptoms the patient should have in order to diagnose him or her with major depressive episode? That's right. The patient should have at least 5 of those 9 depressive symptoms. But when we talk about the persistent depressive disorder, then it's enough and it's sufficient to have at least 2 of those 9 depressive symptoms for at least 2 years in order to diagnose the patient with dysthymia or persistent depressive disorder. And another criteria for PDD is that any remission should last less than 2 months. Persistent depressive disorder has several specifiers. First, the patient may have persistent depressive disorder with pure dysthymic syndrome, which means that the patient has only dysthymia or only the persistent depressive disorder without major depressive episodes. In other words, the criteria for the major depressive episode is never met by this patient. But the patient may also have persistent depressive disorder with intermittent major depressive episodes or persistent depressive disorder with persistent major depressive episodes. These 2 states or these 2 diagnoses are also known as double depression. This is because the patient has dysthymia at their baseline, but at the same time, every once in a while, they fully meet the criteria for the major depressive episode. So they have the major depressive episodes interspersed within this baseline persistent depressive disorder. Okay, we have discussed the persistent depressive disorder as well, and now let's move on to depression with atypical features. There are 5 major symptoms characteristic of the depression with atypical features. The symptoms that we're going to discuss now are those atypical features or atypical symptoms. First, patients with depression with atypical features have something called mood reactivity. What this means is that they have the transient improvement in their mood in response to a positive event. If something happy occurs to them, or if you tell them something joyful or something happy, they may light up and their face may brighten up for a short time, but then they go back to their depressed mood and depressed affect. But still, their mood is reactive to the happy and joyful events in life. Another atypical feature for depression is hypersomnia. Again, the patient with depression with atypical features may sleep for 14-16 hours per day. Hyperphagia is another atypical feature. This is when the patient overeats while having the atypical depressive episode. The fourth atypical feature is the lead-in paralysis. Lead-in paralysis is the feeling of heaviness in the arms and legs. Patients with lead-in paralysis drag their arms and legs, so they feel heaviness in their arms and legs, and this is characteristic for the depression with atypical features. Please don't confuse lead-in paralysis with lead pipe rigidity seen in neuroleptic malignant syndrome. I have seen several students confusing these two things, but lead pipe rigidity is totally different thing. Lead pipe rigidity is when the extremities are extremely rigid in response to the neuroleptic or antipsychotic ingestion, and we'll definitely talk about it when we discuss the psychopharmacology. But here we talk about the lead-in paralysis. They may sound similar, but they're totally different. Okay, and the fifth and the last atypical feature is the interpersonal rejection sensitivity. Generally, all depressed patients may be a little bit more sensitive to interpersonal rejection than the patients with no depression. However, patients with atypical depression are oversensitive to the interpersonal rejection. They are oversensitive. They may even commit a suicide if their loved one or if their significant other rejects them in any way. Depression with atypical features, interestingly, is the most common subtype of depression. Some of us think that the most common subtype is the major depressive disorder, but that's not true. The most common subtype is the depression with atypical features. And the treatment for atypical depression is the same as for the typical depression or major depressive disorder. Again, here we need the CBT and the antidepressants, most likely the SSRIs. Depression with atypical features has been shown to be very responsive to monoamine oxidase inhibitors, or MAOIs. However, MAOIs are still not the first line for atypical depression because of their risks and side effects, especially the hypertensive crisis. Okay, we have now discussed the depression with atypical features, and now I'd like to talk to you about the differentiation of the major depressive episode and the grief. We have already talked about the diagnostic criteria for major depressive disorder, and we are not going to repeat those criteria again here. We are going to talk about the symptoms and signs of the grief, and then we'll compare and contrast the grief with major depressive disorder. The grief reaction is the normal reaction to the loss of the loved one. It's the bereavement. But the thing is, the loss of the loved one can trigger both major depressive disorder or the grief, or persistent complex bereavement disorder, which is in the middle of the MDD and the grief. That's why we need to differentiate these three conditions from each other. The grief reaction, the normal grief reaction, is associated with the waves of grief at the time of the reminders. For example, the patient may feel more sad when when there is their wedding anniversary, or if there is the birthday of the deceased person. Again, they have the waves of grief. In grief reaction, the self-esteem of the patient is usually preserved, and the functional decline is less severe. Yes, they may find it hard to concentrate on their job and on the people around them, but when the patient is in grief, the functional decline is much less severe compared to the major depressive disorder. Patients with major depressive disorder has severely depressed social functioning. Additionally, patients in grief or people in grief commonly want to join the deceased person. So they think of dying, but they don't have the active suicidality. Again, the thoughts of dying is associated with joining the deceased one. But when the patient has the major depressive episode and they want to die, the reason they want to die is that they don't see any hope or any improvement further on in their life. That's not true in grief. So grief is totally focused on the deceased person, while major depressive disorder is focused on the self, on the depressed patient. And additionally, the grief reaction decreases over time. The intensity of the grief decreases over time. Normally, the grief should last anywhere from 6 to 12 months. But if it lasts for more than a year, then we should consider the major depressive disorder, or we should consider persistent complex bereavement disorder. Now let's briefly talk about the PCPD, or persistent complex bereavement disorder. As we already mentioned, it's in the middle between the major depressive disorder and the normal grief. Previously, it was known as the pathological grief or the complicated grief, but now it's a separate diagnosis in the DSM-5 known as the PCBD. And let me teach you a very useful and a very simple way of how to diagnose the patient with PCBD. When the question comes saying that the patient feels sad and depressed after the loss of loved one, then we have three main differential diagnosis. It's either grief or PCBD or the major depressive episode. If the patient fully meets the criteria for a major depressive episode, meaning the duration of at least 2 weeks and at least 5 symptoms out of the 9 depressive symptoms, then it's major depressive disorder. Now, if the criteria for MDD are not met, then it's either grief or PCBD. If the grief reaction lasts less than a year, and if it's mild, and if looks normal, then it's grief. But then if you feel that the grief reaction is prolonged, meaning lasts more than a year, and it's much more severe than the normal grief, then that's when we talk about the persistent complex bereavement disorder. Okay, now that we've talked about differentiating the major depressive episode, grief, and persistent complex bereavement disorder, we will focus on the postpartum mood disturbances. I should have said the peripartum mood disturbances because that's the more correct way of describing the timeline of these three conditions. The peripartum mood disturbances include postpartum blues, major depressive disorder with peripartum onset, and the postpartum psychosis. They may start during the pregnancy, or they start within the 4 weeks after delivery. That's why now we call them the peripartum mood disorders rather than postpartum. This indicates that these mood disturbances can begin during the pregnancy. And the risk for peripartum mood disturbances is increased if the woman has the previous history of mood disorders. It's as if the pregnancy and delivery triggers their mood episodes. The most common peripartum mood disturbance is the postpartum blues. It usually starts around 2 to 3 days after delivery, and normally postpartum blues resolves within 2 weeks. This is when the new moms are tearful and they have depressed affect and fatigue after caring for the child. But very, very importantly, postpartum blues does not meet the full criteria for major depressive disorder. And this is probably the highest deal thing to differentiate the postpartum blues from the MDD with peripartum onset. Again, the mother is tearful, the mother may feel fatigued and down for the first 2 weeks after delivery, but then if the mood disturbance resolves after around 2 weeks, and if it does not meet the criteria for MDD, then that's the postpartum blues. Since the postpartum blues does not meet the full criteria for MDD, then treatment is just supportive, and we need to educate the patient herself, and we also need to educate the patient's family to be more supportive of the lady and of the newborn. But we absolutely need to follow up this lady to assess for the possible progression to the MDD with peripartum onset. Again, if these depressive symptoms worsen and if they last for more than 2 weeks, now we may reconsider the diagnosis and diagnose the patient with MDD with peripartum onset. Let's move on to this diagnosis. MDD with peripartum onset is the second most common peripartum mood disturbance after the postpartum blues. And it's called major depressive disorder with peripartum onset because, again, it can start during the late pregnancy or after delivery. But the major thing is that it fully meets the criteria for major depressive disorder. In other words, the symptoms last for at least 2 weeks and the patient has at least 5 out of those 9 depressive symptoms. But MDD with peripartum onset does not occur more than 1 year after delivery. It starts within the first year after delivery. And we treat the MDD with peripartum onset just like we treat any other type of depression. So CBT and SSRIs are the first line. And the last and the least common peripartum mood disturbance is the postpartum psychosis. The name explains everything. This is psychosis starting after delivery. We have mentioned several times during this episode that psychosis includes hallucinations, delusions, and disorganized thoughts. And the lady may have the mood congruent delusions or hallucinations of harming the baby or harming herself. There are several risk factors for postpartum psychosis. In the beginning, the first pregnancy is the risk factor for postpartum psychosis. Logically speaking, the mother after the first pregnancy and first delivery is less experienced than after the following pregnancies, and this may trigger excessive anxiety and, in severe cases, psychosis in the mother. If there is the family history of postpartum psychosis, then the lady may also develop postpartum psychosis. Bipolar disorder or any psychotic disorder is the risk factor for postpartum psychosis as well. And finally, if there was any recent medication change, especially if we talk about the psychotropic medications, that can lead to postpartum psychosis. It's very important and high yield to know the treatment of postpartum psychosis. We absolutely 100% need to hospitalize the lady and separate her from the baby because there is a significant risk of infanticide in case of postpartum psychosis. Again, we hospitalize the lady and we start the atypical antipsychotics. If the hospitalization and atypical antipsychotics don't help with the postpartum psychosis, then the second line therapy is electroconvulsive therapy. And so now that we've touched the electroconvulsive therapy, let's talk about this procedure. Electroconvulsive therapy is when we place the electrodes on the patient's head and then we deliver electricity to induce the tonic-clonic seizure under anesthesia and the neuromuscular blockade. There are several indications for ECT. First, ECT is used in treatment-resistant depression. If the patient has tried at least 3 different antidepressants without any significant improvement, that's when we can say that the patient has treatment-resistant depression. And this is when we can use the electroconvulsive therapy. Additionally, major depressive disorder with psychotic symptoms is another indication for electroconvulsive therapy. Acute suicidality may also prompt the physicians to perform the electroconvulsive therapy. And finally, refractory catatonia. The patients with refractory catatonia are eligible for electroconvulsive therapy. But on a side note, let me tell you that the first line treatment for catatonia is the benzodiazepines like lorazepam. And then if benzos don't work, then we can certainly use electroconvulsive therapy for catatonia. Another thing that I'd like to tell you about catatonia is that although it was originally associated with psychotic symptoms more than the psychotic disorders more than the mood disorders, now I'd like you to change this perception and to associate catatonia more with the mood disorders. It accompanies mood disorders more commonly than the psychotic disorders. Okay, let's get back to the electroconvulsive therapy. We already mentioned that electroconvulsive therapy induces the tonic-clonic seizure. And there are several adverse effects that the patient should absolutely be aware of before giving the consent to the electroconvulsive therapy. First, the patient may experience headache and slight disorientation after ECT. But the most important side effect that the patient should be aware of is that electroconvulsive therapy leads to partial anterograde and retrograde amnesia. In other words, the patient may forget some things that happened before the electroconvulsive therapy, and she or he may also have difficulty forming the new memories after electroconvulsive therapy. The good thing about the partial anterograde and retrograde amnesia after the ECT is that it's temporary. It usually resolves in 6 months. Additionally, the electroconvulsive therapy has no absolute contraindication, and it's absolutely safe in pregnant ladies and in elderly people. We may think that electroconvulsive therapy looks a little severe and intense and harmful, but that's not true. That's just a misperception. It is safe in pregnant people, pregnant ladies, and also in elderly people. Okay, let's move on to the risk factors for suicide completion. Before we talk about the risk factors for suicide completion, let me talk about what I promised you to talk about. This is the differentiation between suicidal ideation, intent, and plan. Suicidal ideation is when the person has thought about suicide at least once. And I think that many people have thought about suicide at least once in their lifetime. So that's suicidal ideation. That's the least severe of these 3 states of the suicidal thoughts. After suicidal ideation, then we have suicidal intent. This is when the patient has decided to commit a suicide. So they have intended to commit a suicide. They know they will do it. But if the patient has suicidal intent with no plan, then if you ask them how they are going to end their life, they won't know. They won't be able to tell you because they don't have a plan. And then the last and the most severe form of the suicidal thought is the organized plan or suicidal plan. This is when the person has decided to commit a suicide and the person knows how he or she is going to end his or her life. So they may tell you that they are going to hang themselves on the rope in their home, or they may tell you that they may take the sleeping pills and they may overdose on these pills. Again, when the patient has suicidal plan, this is the patient who is at an immediate risk of danger and the suicide. The reason we need to know the difference between these three types of suicidal thoughts is that we need to assess the acute suicidality of the patient. If we see that the patient has suicidal intent or suicidal plan, then we are obliged to hospitalize the patient and to give the patient psychiatric evaluation. We cannot let such patient go and commit a suicide, right? Okay, and one more thing is that asking about suicidality does not plant the suicidal ideas into the patient. That's a very common misperception, but it's simply not true. In fact, it's very helpful to know that whenever you suspect the major depressive disorder or basically any mood disorder, let's say bipolar, you need to assess the patient's suicidality. You absolutely need to ask if the patient has thought or intended to end his or her life. Okay, now let's talk about the risk factors for suicide completion. And the way we can remember these risk factors is by mnemonic said persons. Said persons are more likely to commit a suicide. So S stands for sex. The men are more likely to commit a suicide. And in fact, the men complete suicide more often, but females try the suicide more often. The A in the mnemonic said persons stands for age. And the suicide has the bimodal distribution. In other words, the young adults and the elderly are more likely to commit suicide than the other parts of the population. D stands for depression. We have already mentioned that depressed patients are more likely to kill themselves. P stands for previous attempt of suicide. And here comes the highest yield thing about the risk factors for suicide. Previous attempt of the suicide is the strongest risk factor for the future suicide. In other words, if the person has tried suicide at least once, then there is a huge possibility that this patient will eventually end his or her life with suicide. E stands for ethanol or the other drug use. When the patient has drug intoxication with psychoactive substances, then he or she is more likely to commit a suicide. R stands for rational thinking loss or psychosis. If the patient has the auditory hallucinations that tell him to kill himself or herself, the patient may act upon these hallucinations and commit a suicide. S stands for sickness or the medical illness. Patients who have chronic medical illness, especially incurable illnesses like advanced metastatic cancer, they may commit a suicide. O stands for organized plan, and we talked about how having a plan is the strongest sign of immediate suicide risk. N stands for no spouse or other social support. Again, if the patient doesn't have a family, if the patient lives alone, then nobody will stop them from committing a suicide. And finally, the S stands for stated future intent. Again, we have talked about the suicidal intent, which is in the middle between suicidal plan and the suicidal ideation. It's worth mentioning that the most common method of suicide in the United States is the firearm, and the access to the guns increases the risk of the suicide completion. There are two more risk factors for suicide. First, this is recent psychiatric hospitalization, regardless of the specific psychiatric diagnosis. And the second one is family history of completed suicide. If someone in the patient's family has completed the suicide, then that person is at risk for completing the suicide. There are several protective factors against suicide as well. First, if the patient takes care of his or her comorbidities and the medical illnesses, that protects them from completing the suicide, because alleviating the symptoms of those medical illnesses gives them hope for life and for the future. Also, if they have tight relationship and connection with their family and with their community, this also decreases the risk for the suicide because they have something to live for. They have someone to live for. Additionally, the cultural and religious beliefs which encourage the self-preservation are also protective against the suicide completion. Simply put, the religious person is less likely to commit a suicide. And also, if the patient has these strong problem-solving skills, this can also protect the person from the suicide, because he or she will likely find a way to solve the problem other than by completing a suicide. Okay, now that we've talked about the risk factors for suicide completion, we have finished discussion of the mood disorders, and now we will move on to the anxiety disorders. Let's start the anxiety disorders, and here we'll talk about the panic disorder, the phobias, generalized anxiety disorder, obsessive-compulsive disorder, body dysmorphic disorder, and trichotillomania. Let's start with the panic disorder. Panic disorder is when the patient experiences recurrent panic attacks with excessive fear and the distress. Here's the thing. Having just one panic attack does not mean that the patient has panic disorder. In order for the patient to be diagnosed with panic disorder, she or he should have recurrent more than one panic attack. Additionally, there may be a known trigger or may not. So having the specific trigger for the panic attack is not helpful in diagnosing the panic disorder. The panic attack and the symptoms of the panic attack usually peak in 10 minutes from the onset, and the patients should have at least 4 symptoms out of those symptoms of the panic attack. And let's talk about the symptoms of panic attack. So the patient may feel palpitations due to sympathetic hyperactivity. They may also have the paresthesias. The reason why patients in panic attack may have paresthesias is that these patients commonly hyperventilate. When you hyperventilate, you create respiratory alkalosis in your body. And if you create respiratory alkalosis, you have less hydrogen ions in your blood, which means you have less hydrogen ions bound to the albumin. So more binding sites are now free on the albumin for the calcium. Calcium binds to the albumin, and now the free ionized calcium fraction decreases. When the person has decreased free ionized calcium, this is when the perioral numbness and paresthesias come into play. The patient with panic attack may also have the depersonalization or derealization. Could you please remind me what depersonalization and derealization mean? That's so cool. That's really awesome. I'm so glad that you remember it from our previous episode. Depersonalization means that the patient feels like they are out of their body and they're looking at their body from the outside world. While derealization means that their surrounding and their environment looks strange or weird to them, as if they are not in that environment. The other bodily or somatic symptoms of the panic attack may include the abdominal pain and the nausea. And the patients in panic attack are very fearful of dying. They are afraid that they will die in this panic attack. Another symptom is intense fear of losing control. Patients in panic attack may be thinking that they are going crazy and they're losing control. Okay, the other somatic symptoms also include the lightheadedness, and lightheadedness goes back to the hyperventilation. Again, when you hyperventilate, you decrease the partial pressure of carbon dioxide in your blood. And if we recall the neuroscience, we know that the cerebral blood flow and the tone of the cerebral vessels are directly, so they are dependent on the PCO2. When the PCO2 goes down, we have cerebral vasoconstriction, so that there is decreased cerebral blood flow. And this is what may cause the lightheadedness in panic attack. The patients in panic attack may also have their chest pain due to sympathetic hyperactivity. They may also have chills and choking. And finally, they may experience the sweating and shaking and shortness of breath, again due to sympathetic overdrive. Panic attack has a very strong genetic component. In other words, if somebody in your family or if multiple family members have suffered from panic attack, then you are more likely to suffer from the panic attacks and panic disorder. And then there is increased risk of suicide. And you can imagine that if the person has panic attack, this is very difficult to accept and to realize what is happening. You have these uncontrollable panic attacks and you cannot even know when they are going to occur. And this is why some people end their lives with suicide if they have the panic disorder. Okay, recurrent panic attacks is not enough to diagnose the panic disorder. Except for the recurrent panic attacks, the patient should have at least one of the following three symptoms for at least 1 month. First, the patient should be constantly concerned of additional attacks. In other words, patients with panic disorder commonly think that they are going to have an attack at an inappropriate place and at an inappropriate time. They also worry about the results and consequences of the panic attack. They are worried that they may harm the other people around them, or they may worry that they may harm themselves. And the third symptom is behavioral change related to the panic attacks. Let's imagine ourselves in the shoes of someone with panic disorder. Let's imagine that we have the panic attacks that we cannot control and we don't even know when they occur. So what if they occur in the college or in the university, or what if they occur at job? This is why the patient with panic disorder may lock up himself or herself at home and stop working, stop going to the college or to the university. You can imagine how crippling and how socially disturbing the panic disorder is for that particular patient. All of these symptoms that we talked about are manifestations of fear. If you need to remember one word associated with the panic attack and panic disorder, please remember fear. And if you remember fear, then imagine what happens to you if you're afraid of something. You hyperventilate, you sweat, you have palpitations, you may also have paresthesias. So all of those signs and symptoms of the panic attack come along if you remember the word fear. The treatment for panic disorder is the first line treatment for the acute panic attack is the benzodiazepines. We need to sedate the patient and calm him or her down. But when we talk about the maintenance therapy or chronic therapy, then we need to prescribe the cognitive behavioral therapy and accessorize to the patient. Venlafaxine from the SNRI group is also considered the first line. Okay, again, if we have the patient in panic attack, then we need benzos to calm this patient down. But if the patient is not in panic attack, but is known to have the panic disorder, then we need the maintenance therapy, which is CBT, SSRIs, and possibly venlafaxine too. Okay, we have talked about the panic disorder. Now let's move on to the phobias. Okay, now we'll talk about the phobias. The phobia is excessive, severe fear of a specific object or the situation. And the person experiences the fear when he or she is exposed to the object or when he or she anticipates to be exposed to the object. In other words, you don't have to necessarily be next to your phobic stimulus to have the symptoms of the phobia. Even if you are expecting that you will come across your phobic stimulus, that may invoke anxiety in you. In order to officially diagnose the phobia, the symptoms of the anxiety and fear in response to the phobic stimulus should last at least 6 months. And the patients with phobia often recognize that the fear is excessive and the fear is out of proportion to the phobic stimulus. But still, they cannot control this fear. And I know some people who try to find the rational reasons behind the fear, but this is not how it works. Fear is the emotional state, and the stimulus or the object that you are fearful of doesn't have to be objectively dangerous, doesn't have to be objectively frightening. I have a friend who is terrifically afraid of the pigeons. I myself am dreaded by the spiders. So again, what I'm trying to say is that phobic stimulus can be anything. I also have a friend who is afraid of a specific sculpture, and every time she needs to go around that sculpture, she takes the different route on her road to another place. The treatment for any type of phobia is cognitive behavioral therapy with exposure. It's called exposure therapy, and it's also known as flooding. The word here is pretty much self-explanatory. Let's take me for an example. If you put me in the room full of huge spiders, and if you keep me there for some time, then I will finally get used to spiders and I will finally overcome the fear of the spiders. This is what the exposure therapy is called. So I am exposed to my phobic stimulus, and then I am forced to get used to the phobic stimulus. This is why it's called flooding. So you flood the person with the anxiety and with the fear, but then the person overcomes this fear on his or her own. Another way of treating the phobias is by systemic desensitization. This is when you are in the outpatient settings. You are sitting in front of the counselor or the psychotherapist, and then the psychotherapist makes you imagine the situation where you are closer and closer and closer to your phobic stimulus. As we already mentioned, patients with phobia have anticipatory anxiety as well, meaning even when they think about their phobic stimulus, they feel uncomfortable and they feel distressed. And when you think about the phobic stimulus in front of your counselor, then your counselor teaches you how to stay calm and how to stay composed if you are really exposed to the phobic stimulus. One specific phobia, which definitely needs to be discussed separately, is the social phobia. Social phobia is also known as the social anxiety disorder. This is when the patient has severe anxiety about at least one social situation, which lasts for at least 6 months, just like any other phobia. Patients with social anxiety disorder are afraid of scrutiny by the others. They are afraid of humiliation and embarrassment. This is why they usually avoid the social situations, or they endure the social situation with a very severe distress. And this can cause the marked impairment. You can imagine that if you are afraid of something, you cannot concentrate, you cannot focus on your job at that time because fear takes over you. There is one specific subtype of social anxiety disorder called performance only. So it's performance only social anxiety disorder, also known as the stage fright. Let's talk about the difference between the regular classic social anxiety disorder and the performance only social anxiety disorder. If the patient has the social anxiety disorder, then even if she or he is not in the spotlight but is in public, he or she will feel distressed with the fear of scrutiny. In other words, even if you are among the people, among lots of people, you are constantly worried that something may go wrong and you may embarrass yourself. But if patient has the performance only social anxiety disorder, then they're not worried and they're not anxious when they are among the people. It's only when they get in the spotlight that their symptoms arise. This is why it's called the stage fright. If the patient needs to make a speech, or if the person needs to run the performance on the stage and has the symptoms of social phobia, this is when we say that this is performance only social anxiety disorder. The treatment for social anxiety disorder is again CBT, SSRIs, and SNRIs as well. But if the patient has performance only subtype of the social phobia, then we can use either beta blockers like propranolol or the benzodiazepines approximately 30 to 40 minutes before the performance or speech or whatever. Propranolol is preferred over the benzodiazepine due to almost no abuse and addiction potential. And propranolol is preferred over the other beta blockers because it's a non-selective beta blocker, and it really makes the patient calm. It's not only sympathoplegic, but it also makes the patient calm. Okay, this is the social anxiety disorder. Now let's talk about the agoraphobia. The word agora is the Greek word, and it means the public space. This is the place where ancient Greeks used to gather around. And agoraphobia, logically, means the fear of the public spaces. Now, I'd like you to make a distinction between social anxiety disorder and agoraphobia. If the person has social anxiety disorder, she or he is afraid of being around the other people. She or he is afraid of embarrassment from the other people. But if the patient has agoraphobia, then they are not afraid of embarrassment by the people. No, they are afraid of the public spaces. And they are afraid that if something goes wrong in that public space, they won't be able to escape. This is what they are afraid of. And in order to officially diagnose agoraphobia, the patient should have the fear and anxiety for at least two specific situations or public spaces. This might be the open space or closed space. This might also be the line or the crowd or even the public transport. You can imagine how disabling the agoraphobia can be. If you are afraid of the public spaces or public space, then you may stay in your house, and you may refuse to leave your house for school, for college, for a job. So it can be crippling and it can be socially disabling to have the agoraphobia. Interestingly, agoraphobia is associated with panic disorder. In other words, the patient may have panic disorder and agoraphobia at the same time. But I'd like you to distinguish the panic attack secondary to agoraphobia from the panic disorder. If the patient has panic attack secondary to agoraphobia, this panic attack occurs only in the public space that the patient is afraid of. And it occurs when the patient feels that there is something going wrong and she or he cannot escape. However, when we talk about the panic disorder, the panic attacks secondary to panic disorder can occur anywhere. Panic attacks secondary to the panic disorder can even occur at home. But people with agoraphobia are not afraid of their home, right? They refuse to leave their home to avoid those public spaces. But if they also have the panic disorder, they may experience the panic attack at home as well. And the treatment for agoraphobia is again CBT and SSRIs. Okay, now we'll talk about the generalized anxiety disorder, also known as GAD. If I wanted to summarize the generalized anxiety disorder very simply in one sentence, I would say that this is when the person worries about everything. It's called generalized anxiety disorder because the patient's anxiety is generalized. The patient is anxious and worried and fearful of multiple different things and aspects of their lives. They may worry about their children, they may worry about their job, about their performance, about their personal life, family life. Again, they worry about multiple different things, and this persists for at least 6 months. There are 6 symptoms and signs which are associated with generalized anxiety disorder, and if the adult needs to be diagnosed with generalized anxiety disorder, then the adult should meet at least 3 out of those 6 symptoms. But if we suspect generalized anxiety disorder in the child, then the child should meet at least one of those 6 symptoms. So these symptoms include restlessness. People with GAD are always edgy and they are always restless. Irritability. Another symptom is the sleep disturbance. Then we have fatigue, muscle tension, and difficulty concentrating. I have a question for you guys. Do you remember what we said about the anxiety disorders? Do you remember which type of insomnia the patients with anxiety disorders experience most? Absolutely. They experience the initial insomnia or difficulty falling asleep. And now it should make sense. If you are worried about multiple things in your life, when you lie down in your bed to go sleep, then your mind starts roaming around all of your worries and all of your fears. And this is why the patient with generalized anxiety disorder may have difficulty falling asleep. But let me tell you one thing. Again, anything in psychiatry is considered disorder only if it interferes with the patient's functioning and the patient's day-to-day life. Most of the people that I know of are worried and slightly anxious about multiple things in life. Even I am thinking about many different aspects of my life, but that doesn't mean that we all have generalized anxiety disorder. You may be thinking about your aspects of your life while you lie in your bed at night, but that does not mean that you have GAD. You have generalized anxiety disorder if your worries and if your anxiety gets out of control, if it interferes with your functioning and with your relationships to the family, to the co-workers, to the friends. This is when the anxiety takes over you and just decreases your functioning. Okay, now let's talk about the treatment for generalized anxiety disorder. CBT, SSRIs, and SNRIs are the first line interventions. The second line interventions are also high yield to know for generalized anxiety disorder. These include three drugs. This is the buspirone, tricyclic antidepressants, and benzodiazepines. Buspirone is just the one disease drug. It's an anxiolytic used only in the generalized anxiety disorder. And we'll talk about the buspirone when we discuss the psychopharmacology. And logically, TCAs and benzos are the second line for generalized anxiety disorder due to their side effects and addiction potential. Well, when we talk about addiction potential, here we talk about the benzos, not the TCAs. Okay, now I'd like to talk to you about the obsessive-compulsive disorder. Obsessive-compulsive disorder, or the OCD, as the name implies, is characterized by the obsessions and compulsions. Let's define each of these two terms. Obsession is the recurrent, intrusive thought, feeling, or sensation. This is the thought or the feeling that intrudes your mind and that enters you without your consent. So you may not want that thought or the feeling to experience, but it's still there. And then compulsion is your action or the behavior which partially relieves your obsession and your anxiety about the obsession. So compulsion is the repetitive and often time-consuming actions. And when we say action, we don't necessarily mean the physical action. It might actually be the mental activity or mental action. Let's say that the patient is afraid of germs. And let's say that the patient touched the surface, which is possibly contaminated with germs. Then this patient will have flooding, intrusive thoughts about the contamination and the germs present on his or her skin. And then the compulsion for such patient may be the excessive hand washing or excessive showering. There are many, many different examples of what the obsessions may be and what the compulsions may be. But the main thing is that obsessive-compulsive disorder is ego-dystonic. In other words, the obsessions and compulsions that the patient experiences is not harmonious with their beliefs and their desires. Patients with OCD don't want to have these obsessions about the different things like cleanliness, for example, like precision, symmetry. They don't want to have it. And they also feel that their compulsions and their behaviors are excessive and time consuming, but they cannot stop. They cannot hold it. And this is why they get severely distressed with their obsessions and compulsions. It's also important to know that in order to diagnose the obsessive-compulsive disorder, it should be time-consuming. The patient should be spending at least an hour per day for the obsessions and compulsions, and at the same time, it should be severe enough to disrupt the patient's social functioning. The reason I'm saying this is that some people have the traits of obsessive-compulsive disorder, including me. I have discovered in myself that I have several traits of the obsessive-compulsive disorder, but it does not interfere with my social functioning and it's not time-consuming. That's why I think I don't have the OCD, at least yet. Hopefully I won't. But again, the general theme goes on in psychiatry. Anything that is not disruptive for the social functioning and is not time consuming is not the disorder. Okay? And then we should also remember that Obsessive compulsive disorder is absolutely different from the obsessive compulsive personality disorder, abbreviated as the OCPD. Obsessive compulsive personality disorder is all about order. It's all about perfectionism. Patients with OCPD are perfectionists. They want everything to be done perfectly and on spot. And OCPD is not characterized by obsessions and compulsions. Again, it's about the order, strict order, and perfectionism. And at the same time, OCPD is egosyntonic. People with obsessive compulsive personality disorder like what they're doing. They like that they love order. They like that they are perfectionists and they do everything to the level of the perfection. Okay, the obsessive compulsive disorder is associated with Tourette syndrome, and we have mentioned this connection in the previous episode while we discussed the Tourette syndrome. Could you please remind me which another psychiatric disorder is associated with Tourette syndrome apart from OCD? Amazing. That's simply amazing. It's ADHD. ADHD and OCD are associated with Tourette syndrome. The treatment for obsessive compulsive disorder is CBT and SSRIs together. But the second line treatment is clomipramine or venlafaxine. Venlafaxine is the SNRI, while clomipramine is the TCA. And clomipramine has been shown to be particularly effective in OCD. However, since it's TCA with multiple different side effects, it's still not the first line medication for this condition. Another condition that I'd like to talk to you about is the body dysmorphic disorder. Body dysmorphic disorder can be considered as the subtype of obsessive compulsive disorder. This is when the patient is preoccupied with at least one perceived physical defects. They may think that they have a mole on their skin that looks ugly. They may insist that there's a scar on their skin. And they may actually have those skin defects, but these skin defects are either minor, almost unrecognizable by the other people, or these skin defects are absent. And this is their obsession. So obsession in body dysmorphic disorder is that there's something wrong with their body and there's some kind of scar or the mole or some ugly lesion on their body, and their compulsion is appearance related time consuming behaviors. Patients with body dysmorphic disorder may spend hours in front of the mirror looking at their body. They may engage in excessive grooming. They may request the unnecessary and excessive cosmetic surgeries. All of these can be interpreted as the compulsion in the body dysmorphic disorder. And body dysmorphic disorder, just like the other anxiety disorders, cause significant distress and the impairment in the social functioning of the patient. The patients with body dysmorphic disorder may have the variable insight. And generally, insight is a very important topic when we talk about the psychiatric conditions. So I don't want you to think that insight is only characteristic of the body dysmorphic disorder. Insight simply means whether you realize that there is some problem with the way you feel or the way you think. Some people have good insight. They know that they have the condition, psychiatric condition, and they are often compliant to their medical therapy. Then the patient may also have the poor insight where they kind of realize that there is some problem with their behavior or with the way they feel, but they're not ready to change their patterns of behavior or the feelings. And then we may also have the absent insight. these are the patients who don't see any problem with their behavior. They don't think that they have any kind of psychiatric condition or diagnosis. And you can imagine that the poorer the patient's insight is, the more difficult it is to treat such patient. Okay, and the treatment for the body dysmorphic disorder is again the CBT, and SSRIs. Now, the last anxiety disorder I would like to discuss with you is the trichotillomania. The trichotillomania is the recurrent hair pulling which results in hair loss. It's also known as the hair pulling disorder. Patients with trichotillomania pull out their hairs potentially from any part of their body. However, the most common part of the body from which they pull out their hairs is the scalp. Before we diagnose trichotillomania, we should absolutely exclude all the other medical and dermatological conditions characterized by the hair loss. For example, alopecia areata or telogen effluvium, things like that. But at the same time, the trichotillomania is patchy hair loss. And this is another clue by which we can suspect trichotillomania. Additionally, in order to diagnose the patient with trichotillomania, we should exclude the other psychiatric diagnoses which may present with hair pulling. For example, body dysmorphic disorder that we have discussed several minutes ago can present with hair pulling because the patient may think that in a particular area of the body she or he has excessive hair, and that's body dysmorphic disorder, and the compulsion for this obsession of excessive hair on the body will be hair pulling. But this situation is not trichotillomania. Trichotillomania is when there is the separate diagnosis of hair pulling disorder. Again, as we already mentioned, trichotillomania results in patchy hair loss, and those are the irregular patches of the hair loss. And very, very importantly, the hair shafts that remain in that balded area are of the variable lengths. This is because all the hair shafts in our body, almost all of them, are in the different phases of the hair growth, and that's normal. And when you remove some hair shafts, then the other hair shafts stay in their different length. So again, trichotillomania is associated with the hair shafts of the variable lengths. And trichotillomania is non-inflammatory, non-scarring alopecia, which is another important feature to differentiate trichotillomania from conditions like tinea capitis, which is the fungal infection of the head that can result in scarring alopecia. Okay, and the treatment for trichotillomania is cognitive behavioral therapy. Specifically, the type of therapy that's effective in trichotillomania is called the habit reversal therapy. Habit reversal therapy means that you replace your maladaptive habit with some benign habit. For example, every time the patient wants to pull on the hair, then the patient learns to stroke the head at that time or do some other action which will relieve this desire of pulling out the hair. There is one more thing that I'd like to say about the trichotillomania. Some patients with trichotillomania also eat their hair. It's called trichotillomania with trichophagia. Tricho means hair, phagia means eating, so trichophagia is hair eating. But in order to diagnose trichotillomania, you don't have to have trichophagia. Some patients may eat their own hair after they pull out the hair, but some people may not. So if you have the hair pulling behavior, which is not related to any other psychiatric diagnosis or the medical or dermatological diagnosis, that's when you can say that it's trichotillomania. But if the patient has trichophagia, it can also result in severe GI complications like trichobezoar. Bezoar is this undigestible material or the ball created by some undigestible material which gets lodged in any part of the bowel. And this can cause, for example, small bowel obstruction. This can potentially result in the bowel rupture or infection even. Okay, we have now discussed the trichotillomania as well. And our final subsection for today's episode is the trauma and stress-related disorders. These subsection involves adjustment disorder and the post-traumatic stress disorder. After we are done with this, then we'll talk about the symptom duration of the different diagnosis, and that'll be it. We will wrap up our episode. The adjustment disorder is the psychiatric disorder which occurs within 3 months of a specific psychosocial stressor. And the psychosocial stressor can be potentially anything. It may be an illness or death of a loved one. It may be a divorce. It may be moving out from one town to another, from one country to another. It literally can be anything. But it's very high yield to remember that adjustment disorder starts within 3 months after the stressor occurs, and it lasts less than 6 months once the stressor has ended. The reason we are stressing this 6-month period is that if the symptoms last more than 6 months, then we need to evaluate for the other psychiatric conditions, specifically major depressive disorder or generalized anxiety disorder. Adjustment disorder exists in 2 forms. There is adjustment disorder with depressed mood, and this looks like major depressive disorder. And then we have adjustment disorder with anxious mood, which looks like generalized anxiety disorder. The way we can differentiate adjustment disorder in the question stems and also in the real life is that adjustment disorder never ever meets the criteria for other DSM-5 diagnoses. So when we have adjustment disorder with depressed mood, it does not meet the criteria for major depressive disorder. It does not meet those at least 5 symptoms out of the 9 depressive symptoms. When we have the adjustment disorder with anxious mood, it does not meet the criteria for the generalized anxiety disorder, which was the symptom duration of at least 6 months and at least 3 symptoms in adults out of the 6 GAD symptoms. And this is really how we differentiate adjustment disorder from other DSM-5 diagnoses. If the patient does not meet the criteria for an MDD or GAD, and if there was a specific significant stressor in this patient's life, then we can say that the patient experiences the adjustment disorder. The patient has trouble adjusting to the new way of life or the new lifestyle. The treatment for adjustment disorder is CBT, cognitive behavioral therapy. That's the first line treatment. But if CBT doesn't work, then we may consider antidepressants if we have adjustment disorder with depressed mood, or we may consider anxiolytics if we have adjustment disorder with anxious mood. I would also like to compare and contrast the adjustment disorder with the normal stress response. The psychosocial stressor is called stressor because it causes the stress, the mental stress, whether it's divorce or the illness or the death of a loved one, whether it's moving out of town. The patient may feel stressed about all of these circumstances, but if the person experiences the normal stress response, now here's the thing. The normal stress response is never excessive or out of proportion to the severity of the stressor. And at the same time, normal stress response has no significant functional impairment. Patients who are under the stress can function normally in the family, in their jobs, within their friends, so they can function normally. But that's not true for the adjustment disorder. Adjustment disorder causes significant functional impairment. And at the same time, the emotional response to the stressor is out of proportion to the severity of the stressor. This is how you know the difference between the normal stress response and the adjustment disorder. And trust me, this is very high yield because the questions that need us to diagnose adjustment disorder commonly contain the normal stress response as one of the distractors. And this is why we need to differentiate these two conditions. Okay, now let's move on to the post-traumatic stress disorder, or PTSD. The post-traumatic stress disorder, as the name implies, is the significant distress after the traumatic and painful experience. And the possibility of you developing the PTSD depends on two factors. First, how close was the painful experience to you as a person? And second, how significant was that traumatic experience? Let me give you an example for this. Let's say that you hear the story about the stranger person who was raped and tortured. And when you hear this, you may feel extremely uncomfortable and distressed by this story. However, if that happens to your loved one, or if that happens to you, then you will be devastated by this experience, right? So, if that happens to your loved one or you, you are more likely to develop the post-traumatic stress disorder. On the other hand, if the patient trips up on the floor and falls down, then she or he is not likely to develop the PTSD because that's not something huge, and it's not a very significant traumatic experience. But if the patient is either tortured or raped, or if the patient witnesses the death, this is the experience beyond the normal usual human experience, and that's when the patient is more likely to develop the PTSD, because the magnitude of this effect and magnitude of this experience is huge. And the symptoms of the PTSD can be remembered by the word hard. So PTSD is hard. H stands for hyperarousal. Patients with PTSD are constantly on edge, and they are very alert. They have very soft sleep, so they can wake up even on a small noise. The letter A in the word hard stands for avoidance of associated stimuli. Let's say that the patient was raped or was tortured in a certain district or the area of the town. Then this patient, after developing PTSD, will likely avoid that area altogether, even if it means that he will need more time to get to a particular destination. R stands for re-experiencing of the event. And the re-experience of this traumatic event may happen in two major forms. It usually happens in nightmares, or it also happens in the form of flashbacks. Let me take a side note and talk to you about the flashbacks. Some of us think that the flashback is simply thinking about that traumatic experience, but that's simply not true. Flashback is experiencing that traumatic experience from the beginning. So people who have the flashbacks due to their PTSD feel that they are in that painful experience again, and in their minds, their surroundings change and the people around them change. So if the patient with PTSD is experiencing the flashback, she or he may be danger to himself or herself and to the other people as well. And D stands for distress. But the patients with PTSD may experience excessive fear and horror, and they may have the personality changes. Many times, patients who were previously described to be very polite, very sweet, and then develop PTSD are described to become very rude and irritable and inconsiderate of the other people. And all of these signs and symptoms can be united under one word, which is distress. it's very, very high yield to remember that the symptoms of PTSD should last more than 1 month in order to diagnose the patient with PTSD. Otherwise, the patient is diagnosed with acute stress disorder. Acute stress disorder also occurs after significant traumatic experience, but acute stress disorder lasts anywhere from 3 days to 1 month. If the symptoms and signs last more than 1 month, then the patient is reclassified to have the PTSD rather than the acute stress disorder. The treatment for the post-traumatic stress disorder includes cognitive behavioral therapy, SSRIs, and venlafaxine. These are the first-line interventions. But it's very high yield to remember that there is one drug which decreases or reduces the nightmares in patients with PTSD. Could you please tell me which medication reduces the nightmares in PTSD? That's awesome. That's amazing. It's prazosin, alpha-1 antagonist, which has been shown to reduce the nightmares in patients with PTSD. Now, as for the acute stress disorder, the only treatment the patients with acute stress disorder need is the cognitive behavioral therapy. They don't need pharmacotherapy. But if the symptoms last again more than 1 month, then the patient has PTSD and we need to start the psychopharmacotherapy. Okay, now let's talk about the symptom duration of the different disorders and then we'll wrap up this episode. First, let's talk about the sleep disorder called narcolepsy. Here we are not going to discuss narcolepsy in detail because I realize that this episode is probably the longest episode that we've had in Zoo's family. But the only thing that we are going to say here is that narcolepsy lasts more than 3 months. It should last more than 3 months in order to diagnose the patient with narcolepsy. More on narcolepsy in our upcoming episodes of the Psychiatry series. Now let's move on to the childhood disorders. As we already discussed, the selective mutism and separation anxiety disorder last more than 1 month. In contrast, the ADHD, specific learning disorder, and oppositional defiant disorder last more than 6 months. And finally, the chronic tic disorder, Tourette syndrome, and disruptive mood dysregulation disorder last more than 1 year. Okay, now let's talk about the time frame of the psychotic disorders. We know that delusional disorder lasts more than 1 month. Pre-psychotic disorder lasts less than 1 month. Schizophreniform disorder lasts from 1 to 6 months, and then schizophrenia lasts more than 6 months. As for the mood disorders, today we said that manic episode of bipolar 1 lasts at least 1 week. Major depressive episode lasts at least 2 weeks. And finally, dysthymia and cyclothymia lasts at least 2 years. Okay, and then finally, let's talk about the time frame of the anxiety disorders. Panic disorder lasts more than 1 month. Phobias and generalized anxiety disorder last more than 6 months. Adjustment disorder lasts less than 6 months. Acute stress disorder lasts less than 1 month, while post-traumatic stress disorder, or the PTSD, lasts more than a month. Okay, wow, this was a long episode. We've discussed multiple different topics across the psychiatry, and now let's summarize everything very briefly that we've discussed in this episode.